everyone. Good morning, good afternoon, good evening. Nasaan man po kayo, parte ng mundo. Welcome to the 79th installment of the Stop COVID Deaths webinar series. And it's the start of our 7th season for our webinar series. Thank you for being part of our credible online community. And to all those who have just discovered us for today, welcome po. At sana po masiyahan po kayo at tuloy-tuloy na po ang inyong panonood at pag-join sa amin each and every Friday. So, ang pag-uusapan po natin, nakita nyo rin po sa ating mga posters, is about COVID-19 testing. Testing po, it always plays an important role kapag may mga outbreak, pag may mga kumakalat ng mga sakit, may pandemya, katulad po na ngayon. And prior to the vaccination, we had to rely on testing to provide us with a little bit of information kung paano man po kumakalat ang sakit, gano'n na po karami ang nagkakasakit, at para mas tulungan din po ang mga contact tracers po natin. If someone had symptoms and tested positive, ina-isolate po natin po kagad yan. If someone was exposed at may test po siya at na-test po siya at the right time, that will tell if the exposure has resulted in an infection. However, mapapansin nyo rin po over the past, 19-20 months po, no? Meron pong kakulangan in terms of the number of tests being done, lalo na po nung wala pa po tayo mga vaccines. Yun po talaga yung ating ginagamit po kasing guide para po magkaroon po tayo more targeted approach sa pagsugpo sa pandemyang ito. Ngayon pong may bakuna na po tayo, the equation has changed. So people in the National Capital Region are now more than 90% are fully vaccinated. That has provided some protection against the deadly COVID virus, but not an assurance that we are completely protected or unprotected. Many who have received, lalo na po ang sikat na Chinese brand, are having tests done by themselves and would like to receive other vaccines based on their antibody titers, gano'n pa po karami ang kanilang antibodies, kumbaga. So, sa kakulangan po ng, shall we say, clear guidance on how to use and maybe interpret all of the different tests that we have right now, swab, saliva, antigen, we will continue to see irrational use of testing and perhaps unnecessary expenses, as well as some sort of frustration po from testing when not needed, failing to test when needed. So, for our webinar for today, if you want to learn the latest developments kaugnay po ng COVID-19 testing straight from the most credible experts, please stay tuned, and I hope you'll be able to learn more after this webinar. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday lunch date. And always look forward to sharing hosting duties with a beloved mentor, the President's Special Envoy for Global Health Initiatives and our adjunct research faculty at the National Telehealth Center, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, good afternoon, Raymond. Magandang hapon po sa inyo lahat. Saan man kayo naroon. I hope you're all doing well, you're in good health, and parang nakakahinga na ng konti. Although, syempre, alam nating up and down, no? Hindi natin alam kung gano'ng katagal. But it's good news to hear that there's some opening up. But as Raymond said, it'd be very interesting for us to talk a little bit more about testing kasi parang puro bakuna yung pinag-uusapan. Kalimutan din na natin na importante rin yung testing at maraming mga pagbabago sa testing. So malalaman po natin ang tungkol sa mga bagong test sa pamamagitan ng ating mga experts. And we do have some very good experts today who you will learn a lot from. So we're looking forward to that. I'd like to greet everyone who's watching us on Facebook and on the playback and YouTube. Mabuti naman at nakakapagtipon tayo, no? And sa mga nandito for in the Zoom, we are here because of you, no? So kung hindi sa inyo, hindi naman kami magkakaroon ng webinar na ganito. Natutuwa lang kami na marami sa inyo talagang regularly nandito pag Friday. So binabati ko kayong lahat, especially those who are watching from far off places. So today I could see again Isabela, Davao, Zamboanga, no, and all of our friends in the National Capital Region sa ating mga DOH retained hospitals. So binabati ko kayong lahat, and I hope that today will be a productive day and you will learn a lot from our experts about testing. So huwag nating kalimutan na habang tumatagal ang panahon, nagbabago rin ang teknolohiya at nagiging mas mahusay tayo dun sa testing. So aalamin natin yan mamaya. Raymond, over to you.
Thank you, Dr. Susie. So, para na rin po sa ating mga very first time na makakasama for this webinar series, we always have this very brief na video na tinatawag po nating burn on the street pulse of the common folks po with regards to our with our specific topic in order to put our discussion in context. That's something that we really hope will be helpful as you try to learn po throughout the webinar. For our person on the street interview video, ang katanungan po na itatanong for today, kailangan ko po ba magpa-COVID-19 test para po makapasok po sa trabaho o kaya sa eskwela? So TVUP, take it away and hope our audience watches this.
Okay, so my stand on this question po would be no. I don't think that it is necessary to require individuals to undergo COVID-19 test for them na makapasok sa trabaho o sa eskwela. So I have two reasons why I came up with my answer. First, setting this as a requirement would be pricey on the part of workers and students. Unless po siguro if the expenses are covered by company or health insurance. So we need to acknowledge po that not everyone is fortunate enough to have the financial capacity para makapagpa-test.
I think it's a necessity magkaroon ng COVID testing, but yes, especially na magkakaroon na ng approved na IITF, yung limited face-to-face classes, ganun. But I think it's very ideal kung like on a daily basis pa siya gagawin yung COVID testing or like major scale since but possible na maging expensive siya.
Kailangan pong magpa-COVID testing pa rin yung mga manggagawa na papasok sa kanilang trabaho, same time yung mga estudyante papasok sa kanilang mga paaralan, as long as gastos ito ng sagot ito ng boss ng kumpanya, yun, at sagot naman ng eskwelahan. Huwag nating ibigay yung gastos at dagdag hassle pa sa mga manggagawa at mga estudyante dahil sila yung isa sa mga pinahirapan ng pandemya ito.
So for students po, most probably they will be offered with an alternative solution po, which is for them to continue siguro distance or online learning. But it is more unfair, I think, para sa mga workers, especially if work from home is not applicable to the types of job that they have.
I think vaccination po is the very number one solution if gusto po nating magkaroon ng herd immunity as soon as possible, and yes, yung safety protocols din ganyan, and I think we pwede rin as an individual myself, I think we should be more active. We take vitamins ganyan, try to live in a healthier lifestyle and so on.
And effective pa rin naman yung COVID testing as long depende kung ano yung test na yun. Kasi ano rin siya parang ano na rin siya sa kaluwagan ng pag-iisip ng mga katrabaho ninyo, lalong-lalo na sa mga medyo natatakot dahil may umuwi sila sa pamilya nila na may mga matatanda o mas bata. Ayun, para kapanatagan ng loob. So kailangan ng COVID testing.
Honestly, many factors to consider. That's why I'm not agreeing na kailangan pa magpa-COVID-19 test para makapasok sa trabaho or sa eskwela. A more practical approach siguro could be applied. Few of those ay to ensure na lang na individuals receive their full dose of vaccine, which is totally free, by the way.
Siyempre, naniniwala naman tayo sa science. So sa kabila ng differences natin sa opinion, kung religion man yan, kung anong pinaghugutan nito, hinihimo ko yung mga magagawa at lahat ng mga kababayan ng Pilipino na magpabakuna dahil may basihan naman ito na scientifically. Ayan, so sana magpabakuna tayo lahat.
Okay, thank you very much. Thank you very much, TVUP. It's always very nice to take the perspective of ordinary people when you ask the question, and obviously the big concern is cost. No, parang when we look at what's going on in the rest of the world, Singapore, the US, the UK, Canada, Germany, they're all opening up and using antigen tests for workers and for schools. But it's not at the cost of the individual, no? Parang ito po ay sinasalo ng pamahalaan. The government pays for it, or private companies. I was just talking to a friend of mine in Japan. Private companies have to pay for it, but they get tax incentives for covering COVID costs. So there is a way of financing COVID tests. Hindi naman yun ang pag-uusapan natin ngayon, pero Raymond, pero dahil na ibanggit yan, no, parang we can't say that we cannot afford it, because I think we cannot not afford it. We need to continue to test because we will not know where the disease, from a public health point of view, where the disease is. No, but they're right. Our young people who were interviewed are right na pagpabakuna lahat. Tama naman yun. Pero alam din natin na maraming breakthrough infection. No? Kahit na nabakunahan, nagkakaroon pa rin ng COVID. Anyway, pag-uusapan ng mga experts natin yan mamaya. So Raymond, over to you. Thank you, TVUP. Thank you.
And thank you, TVUP, and thank you, Dr. Susie. We are now numbering almost 600 participants in the Zoom. Medyo mabagal lang po ang trickle in, but we hope yung pong mga nakapag-register and will be able to join in Zoom can join us, because we are able to accommodate up to a maximum of 3,000 participants. If you are watching in YouTube or Facebook, sana po you'll have the chance, if not to, this time, maybe next time, to join us to get the full experience of our online community by joining in the Zoom. Please put a shout out po dun sa comment section kung nandun po kayo sa YouTube at sa Facebook pages po ng University of the Philippines, TVUP, and Stop COVID Deaths. Meron po tayong iba't ibang mga parallel discussions na nangyayari, and there will be members of the team who will be monitoring yung mga chat boxes mo, not just in the Zoom but those who are watching us in our live streaming channels. We would also like to invite everyone to participate, nasa Zoom man po kayo o hindi, in our fun quiz. So the questions that we have for our Zoom poll are the very same questions that we have for our Mentimeter. For those who are joining us for the very first time, what that means is that you open your internet browser and go to www.menti.com and use the code 78876872. That's 78876872 for you to be able to participate in our fun quiz. So sana po you'll be able to join. That's something that provides us with an inkling of what you already know about the topic. For those who are asking, lalo na po sa week in and week out na nag-email, the certificates of attendance will be given to those who have watched at least 50% of the webinar duration. So yun po, please let us know. We have already distributed up to webinar 77 completely. Webinar 78, I think there are still a few more that we want to be able to get out. But please let us know po if you think that you should be receiving your certificate but have not received it po. For those who have joined us, naalala nyo po, I think it was last month, a few weeks ago, nagkaroon po tayo ng ating game show, no? That was webinar 75. Ang title po ng Fact or Fake, Be COVID-19 Social Media Smart. For the winners, please expect an email from the Stop COVID Deaths team with the pick-up instructions ng inyong prize at your selected UP constituent university as indicated in the Google form that you have filled up. Now, we are mentioning this because we have received a lot of messages regarding those who would want to pick up po ang kanilang mga prizes, lalo na po na ngayon na medyo maluwag na po at makakapaglabas at makakapunta na po sa kanilang mga selected UP constituent universities. If you cannot, if you're not able to find it in your email inboxes, baka po nasa spam folder po ninyo, at please check it din po para po malaman po natin na kung nandun na po yung instructions. Again, we would like to acknowledge San Miguel Foods, the food division of San Miguel Food and Beverage Incorporated, for the gift packages. They have, essentially generously sponsored during the webinar number 75. At maraming salamat po sa lahat po ng nakilahok sa ating game show who are part of our credible online community. Over to you, Dr. Susie.
Okay, thank you very much, Raymond, for the announcements. So nga, may nagtatanong nasa na daw yung kanilang mga food pack. Okay, so we're taking care of that. All right, so let's go to our opening speaker. So we typically invite a very distinguished guest to give some opening remarks and set the tone for the webinar. And I'd like to welcome Dr. Nelson Geraldino, the chair of the Department of Laboratories of the Philippine General Hospital. Welcome po, Dr. Geraldino.
Yes, good afternoon. Unfortunately, the webinar does not come with lunch, no? So, mercifully, we have Raul and other experts on hand to discuss their takes on the current trends in virus testing. So let me tell you, it is not easy to be a virus. No? With SARS-CoV, it was able to take root and cause so much destruction, morbidity, and mortality in populations everywhere because it is a newly evolved virus. So I am sure that Raul is going to discuss the differences in testing that are occurring currently versus what was happening at the start of this pandemic and in the middle of this pandemic, that is around the beginning of this year. I have noticed from the comments that many of the issues stem from the kinds of tests, how convenient it is going to be for the testees or for the people in the streets, for students and for workers. And also many of them are aware and very apprehensive of the cost of testing. But in the end, for medical practitioners and for the Department of Health, accuracy is the biggest factor. So for this afternoon, Dr. Jonathan Rivera is going to show you some data from the Philippine General Hospital regarding how we do things, our output since the start of the pandemic, what we have been detecting in the virus strains. And hopefully Dr. Destura is going to give us some more insights into what the future, the very near future, next month, next year, is going to bring for everyone. So with that, thank you very much. And welcome to the webinar.
Thank you very much, Dr. Geraldino, for being with us today and for just sharing your time with us. No, we know you're very busy, but it's so important to have you and to have you here at the webinar today. Maraming salamat po. Okay, Raymond, over to you. We are now going to our fun quiz.
Fun quiz. Okay. Thank you so much, Sir Nelson. No? It's not every day that we are graced with your presence. So we really appreciate you taking the time out from your busy schedule. Thank you so much, sir. We now move on sa ating fun quiz. There we go. We are now seeing on the screen, at least in Zoom, there we go, for Mentimeter also, the two questions that will be posed for us for today. Ang una pong katanungan, anong COVID-19 test ang tingin mo ang pinakamahusay? What COVID-19 test do you think is the best? The first option is RT-PCR swab. Second option, RT-PCR saliva. Third option, rapid antigen. And fourth option, rapid antibody. We are seeing almost 200 participants, at least in the Zoom, joining in, 76 in Mentimeter. Hopefully, mas marami pa po ang mag-join sa ating fun quiz. Hindi naman po ito graded, so please sana po makasali po kayo sa ating Mentimeter poll and Zoom poll po. We would like to greet those who are joining us from Benigno V. Aldana, National High School in Pozo Rubio, Pangasinan, Commission on Population and Development Region 3 in San Fernando, Pampanga, the Provincial Health Office, Provincial Epidemiology and Surveillance Unit in Trece Martires City in Cavite, Corazon Locsin, Montelibano, Memorial Regional Hospital in Bacolod, Negros Occidental, and the Ministry of Health in BARM, the Bangsamoro Autonomous Region in Muslim Mindanao. Internationally, we are also being viewed po. We have already greeted those from Algeria, but we hope to greet those who are joining us from Chonin Hospital in Taipei, Taiwan, Nguyen Thai Hoc Polyclinic in Vietnam, Penang, Malaysia, Dubai, United Arab Emirates, Taif, Saudi Arabia, Lunichi Alib University of Blida 2, and University of Rigi, Lautoka, and Stockton, California. Bago po yun, si Stockton, California. Maraming salamat po. For question number 2, kapag nag-positive ako sa COVID-19 test, makakabiyahe pa rin po ako. So for the benefit of those who are watching us internationally, if I test positive for COVID-19 test, will I still be able to travel? It's a true or false question. We are seeing 78 participants in Mentimeter answering the questions, and a little over 400 in the Zoom poll. So please let us know if you're encountering any problems po, no? That's why you're choosing to put it in the chat. But anyway, we will not be closing the poll as we move on to our main speaker. Dr. Susie?
Very cute talaga yan, Raymond. Gusto ko talaga yung mga, ayan, dumadami pa. Oh. Okay, so thank you for participating in that fun quiz, and it's my honor to present our first speaker. We're always happy to have him on the webinar. He is known to you. Simulat sa poll, sinasama na namin to sa discussion. He is one of our world-class Filipino scientists, and we're very proud of him because he was the first one to develop a Philippine COVID test. Alam niyo na kung sino, di ba? Dapat tagay natin sa poll quiz yan, you know? Sino yung mga sikat na scientist natin? Anyway, so I'd like to welcome Dr. Raul Destura, professor of the UP College of Medicine. He is also Deputy Director for Strategic Initiatives and Emerging Programs, Director of the National Training Center for Biosafety and Biosecurity at the University of the Philippines National Institutes of Health, and idol ko po yan. So welcome, Raul.
Thank you, Ma'am Susie, for the very generous introduction. So will I proceed now with my lecture, or?
Yeah, go ahead,
Yes,
go ahead.
Okay. Excited masyado, no? Oo.
Oh, excited kami. Oh, game.
Thank you for having me here at the TVUP webinar, and I will be presenting to you everything about, but not everything, the highlights about COVID-19 testing, and perhaps will provide you some of the nuances around the test para mabilis nating maintindihan bakit itong test na to ay hindi appropriate sa ganitong kondisyon, and vice versa. So can you see my slides?
Yes, sir. Go ahead.
All right. Okay. So we will be discussing about SARS-CoV.
Dr. Raul, medyo putol siya sa baba.
Putol. Hold on. Let me gumagawa siya ng sarili na naman siyang isip. Hold on. I think I know the problem now. It's my computer. Let me. All right. Here we go. One more time. Putol pa rin ba?
Yes, sir. It's still cut off sa baba.
Okay.
Raul, on the right side.
On the right
And on
side.
the right side, yes, para siyang iba yung dimension, sir.
Okay. So, nangyari na ito sa akin in one of my lectures as well. So, let me see if I can...
Yun! There we go.
Okay.
Perfect.
Thank you. Sorry about the technical. Kasi hindi magiging totoo ang digital experience pag hindi tayo makaka-experience ng digital glitches. Yun ang aking palusot. So basically, we'll focus on the viral dynamics, discussions on the different platforms for COVID-19 testing, and some of the platforms that are not practical in its implementation sense, but can be useful on specific need, no, but not really for general need. And some discussions on what are the unmet needs of the current diagnostics, and some issues that I'm glad na raised na kanina sa opening salvo ng webinar natin. So this is how it looks like right now as of 4:27 p.m. November 18, 2021. Clearly, there's still the COVID virus is still raging on in most parts no country. But take note that these are the degree of intensity so far based on cumulative number of cases. So pag tinignan natin ito yung intensity ng picture ng COVID, how it affected the world no as we speak no. And there are about 5 million deaths already globally, and 254 million confirmed cases since the start of the pandemic, and it's actually distributed in this area, from the Americas down to the African region. Sometimes the number is not because they don't have much cases. Sometimes the number is because they don't have access to a diagnostic tool to confirm cases. So those are some of the nuances in terms of interpreting data for reporting to the global community. This is where we are as of this morning from the COVID tracker of the Department of Health website. We had a total of 2,821,753 cases plus 1,297 added on November 18. 23 active cases, more than 2 million recovered, 46,422 died. If you look at the diagnostic positivity trend based on reporting to the national data, you are seeing a significant drop in the number of positive cases in this area. So which means that our vaccination program may have a lot of impact in what's happening right now. At the same time, there are still a lot of people who are conscious about protecting their community and their family members who continually wear their masks and do social distancing despite the vaccination. So maybe these are some of the reasons why we're able to reduce further the number of cases. Although when you see again what's happening in the malls and all, medyo maninervyos ka ng konti about the number of people in the malls, but I would understand because of more than almost 2 years of repeated lockdowns and restrictions, talagang there is hunger for people to be out there because humans are social beings. No? We just need to be very conscious about there may be some consequences, but I hope that the speed and the degree of vaccination and the spread will have an impact in mitigating these events that usually triggers as a spreader events in the past. No? So right now, we're looking at number of samples that has already been tested. 23 million has been tested, and our current positivity rate cumulatively is down to 13.4. But the current positivity rate is actually lower than 13. This is just a cumulative over the years. Now let's go to viral dynamics of the SARS-CoV virus. And this is where diagnostics comes in terms of usability, and this is where also some of the failures of the technology actually detected. So in terms of the viral transmission and how it behaves, it's divided into two periods: latent and infectious period. In this case, between 0 to the 3rd day of from exposure, normally the virological burden is not that high. So when you would request for a diagnostic test, Di ba minsan nagtatanong tayo, pag pinagpapakonsulta sa doktor, sasabihin, na-exposed po ako sa isang positive cases, gusto ko pong magpa-test kaagad, no? Sasabihin ng doktor, mag-antay ka muna ng at least on the 4th day or the 5th day, saka ka magpa-test. Kasi baka masayang lang yung gastos mo kasi baka nasa latent period ka and your testing would likely be negative. So in order to protect yourself while waiting for the appropriate time to be tested, you isolate yourself. And then because if you isolate yourself and then you develop symptoms on the 3rd and 4th day, you are now under the infectious period. But since you already anticipated that, you already protected your loved ones and your friends and your peers and your community not to get exposed to what you have. No? In this case, sinasabi na the infectious period is between 3 to day 17, but we all know that this actually has changed over time. No? That the degree of infectiousness has decreased to less than 2 weeks of the illness. Though. But there are special situations wherein the virus remains viable, especially those that are severely immunocompromised or do not have the ability to develop an immune response since the virus are actually thriving longer than they should in the body. But generally, if your immune system is intact, the duration of infectivity is a little bit lower, but the degree of positivity of your test could be longer than your infectiousness. So these are the ones that are a little bit challenging kasi pag ginagamit natin yung PCR test to determine infectivity, medyo maraming gray zone doon sa area. In terms of clinical presentation, you will see here during the incubation process, mayroon ditong part na hindi ka pa nag-develop ng sintomas, nakakahawa ka na. And then if you develop symptoms, kaya tayo nagkakaroon ng contact tracing. No? And that's the reason why we do contact tracing kasi ito yung mga na-exposed, baka nag-incubate at wala silang nararamdaman at nakakahawa sila sa iba. Until such time that your symptoms are actually resolved, which means that you're no longer infectious. So now, I hope that you guys remember this slide set because it gives us a nice representation of how diagnostic technologies can actually be useful and which type of analytical samples are actually useful in identifying the right technology for the right sample. If you notice here, between -1 and -2 weeks before the onset of symptom, there is already some form of elevation of the virus, but it may not yet still be detectable by existing technology so far. Because you need a critical number of inoculum size, for it to be detected by your assay. So if you notice here, the solid blue and red line represents nasopharyngeal swab PCR, the blue line, detectability between week 1, week 2, and starts going down on the 3rd week. But we've seen cases that remains persistently positive over the 4, 5, or 6 weeks. Kaya lang pag titignan mo yung kanilang cycling threshold values, pataas na yung number. Meaning pag pataas yung number, pababa ang viral copies na napipick up ng PCR technology. Remember, PCR positivity does not discriminate live and dead viruses. So, importante pa rin na pag may nakikita kayong resulta, to ask your doctor about it. Get the appropriate interpretations based on your clinical presentation in relation to your onset of symptoms and the host condition that tested positive. So, hindi lang siya parang you rely on the test right away kasi that's one of the most non-stop text consults I receive from my colleagues about this information. So I try my best to provide as much as I can information. Pag hindi ko alam, hinahanap ko na lang yung sagot para makatulong. So The increase in the probability of detection by polymerase chain reaction is likely between week 1 and week 2, pinakamataas. Now, if you look at antibody detection test, no, normally nakikita siya doon sa towards the second week of illness, medyo mas mataas yung kanyang likelihood to be detected, no, than the first week of illness. In terms of isolating the virus, the likelihood of viral isolation for them to grow is within the first week of illness towards the early part of the second week. And beyond that, hindi na sila tumutubo, which makes you ask, PCR positivity versus viral viability are two different entities in interpreting infectivity. So that's why PCR positivity alone may not be enough to make decisions that you are infectious or not on a clinical standpoint. But when you're talking about public health standpoint, sometimes the interpretations will be different because you now include public health risk mitigation planning. And that way, some decisions are applicable for public health control. Some decisions needs to be patient-based interpretation by your attending physician. You normally, sometimes hindi nagmamatch yung dalawang approaches, and that's why you have to also respect the interpretations of our public health specialists on the utilization of this technology. For antigen detection, it's almost concurrent with the ability of the virus to be detected directly. So if you do antigen detection, the indication is almost similar with PCR in the week 1 of the disease. No? And it goes down, meaning the diagnostic accuracy drops also over time. These are some of the areas where the indications for diagnostic testing can actually be used for clinical decision, for test developers, for policymakers and clinicians that would need to consider that each of the diagnostic use needs to be done with the intention of testing and the population being tested in terms of the decision process. So like, for example, in this case, are there technologies that we can use to screen asymptomatic patients because they are still incubating? Are there technologies that can be used for monitoring contacts during the incubation process? So these technologies, if available, can actually be useful for active and passive surveillance. Unfortunately, there are no perfect tests that can do screening of asymptomatic individuals because some of them may or may not test positive by PCR because of the curve I have shown you a while ago. But doesn't mean that they will not have the potential to infect other people. Kaya from a public health standard, it's not just test, but it's also isolate, and keep yourself. These are the principles why. The other thing that utilizations for indications for diagnostic testing is for increased screening of symptomatic patients and establishing the diagnosis, which is the most common indications for the diagnostic tools. In some cases, it's being used for treatment initiation decisions. But basically, because of the nature of the disease, the decision tools for treatment, for diagnostic testing is not mainly to establish a diagnosis, but actually to determine the dynamics of the disease. So in this case, PCR technologies may have very little role in initiating treatment decision, but will have a huge role in establishing the diagnosis during the symptomatic phase of illness. The next indication is, are there technologies that can help us de-isolate our patients or can be used for monitoring of shedding? Of course, there are, but the problem is from a public health standpoint, the best de-isolation tool is really determine viral viability, which means viral cultures. And just using the word viral cultures is like, a crazy idea because it's very expensive, it's very tedious, and requires a high containment facility to do all of these procedures. That's why it's very important that studies done on viral infectivity on a clinical setting established so that you can make decision based on the duration of your isolation days. No? And the need for a repeat testing or monitoring of shedding over time with the knowledge coming in are no longer being required. So the timing of the diagnostic testing in relation to the infection is critical in the utility and accuracy of COVID-19 diagnosis. There are three major platforms that I will be discussing with you today, and then a new one that's always been from experience being asked to me all the time. So might as well parang isang sabihan na rin para mabawasan yung phone consults. Okay lang naman. So it's based on molecular testing, serological testing, and the non-invasive procedure in this case. So when you say serological testing, it's actually divided into three major groupings. You have the enzyme-linked immunosorbent assay platform. You have the lateral flow immunoassay platform and the chemiluminescent immunoassay platform. Now, this is a systematic review of the pooled sensitivity of enzyme-linked immunosorbent assay platform that is affected in terms of the dynamics of the disease process from the first week to the third week. Now, if you remember the curve kanina, so you could really see that the antibody generation is happening towards the later part of the disease. That's why when you do ELISA for antibody testing in the first week of illness, you will really have very poor sensitivity. It's not because that the test is bad, it's simply because of the natural dynamics of the immune response. So talagang may critical value, may critical limit ang mga assay on its ability to pick up minuscule levels of the antibody response in the first week of illness. Hence, the sensitivity is that low. No? Marami nang nag-attempt na tumbling, combining, capture ELISA, and all of these days methodology to increase and highlight even minuscule levels of the antibody to be able to pick up as early as you can. But basically, it's still a challenge for tech developers to make serological testing or antibody testing useful for acute case detection. It's always like in the convalescent side. So if you notice, the sensitivity gets higher and higher and higher on the third week. So if your purpose is active case detection, this may not be the test that you need. But if your purpose is seroprevalence study, how many in that population are actually serologically positive, which means has been exposed in the past? Then this can be a useful tool to determine the seroprevalence of that particular population. So based on the 9 pooled studies between infected and non-infected, the pooled sensitivity is 84.3%, and the pooled specificity is 97.6% beyond several weeks of testing now. So they really cumulatively nag-i-increase ang kanilang sensitivity. Now, the other one is lateral flow immunoassay. Similar behavior. Kasi whether it is ELISA or lateral flow immunoassay, they are actually working on the same challenges in the diagnostic arm, which means they are dependent on the intensity of the antibody response over time. And knowing that based on the curve again, the antibody is lower on the first week and continues to increase on the second and the third week. So naturally, your lateral flow immunoassay will pick up more of the antibody as the days pass, from the time the patient started having symptoms. So the pooled sensitivity for lateral flow is significantly lower with ELISA, and that's of course it's not unique to COVID. Yung degree of reactivity generally mas higher ang ELISA-based platform than the lateral flow. Although in specific diseases, halos pareho na sila, like HIV and all the others. The other one is the chemiluminescent immunoassay that combines fluorescence signals and chemical reactions that are being detected by a unit, no, that measures luminescent technology. No? So this one has the highest pooled sensitivity, no, of 97.8% and a pooled specificity of 97.8% as well. But again, uh, it is this is a pooled sensitivity on the third week, no? Kasi tumataas talaga yung kanilang diagnostic threshold over time. So, but based on the systematic review of studies, the higher quality clinical studies assessing the diagnostic accuracy of serological tests for COVID-19 are still needed up to now. Currently available evidence does not support the continued use of existing point-of-care serological tests for acute case detection. Let me clarify that, for acute case detection. Now, there's another ongoing technology now, which is the neutralization antibody detection test developed by GenScript. I think it's called the CPAS SARS-CoV-2 neutralization antibody kit. No? This is like a surrogate version of the standard neutralization testing, which is either a plaque reduction neutralization test or a micro neutralization test, or the pseudoviral neutralization testing, which are the ones actually being used as standard diagnostic tool to determine vaccine efficacy studies or neutralizing antibody. This particular technology developed by a team in Singapore, I think that's Duke National University of Singapore, developed the neutralization antibody by copying a certain portion of the virus. No? So in this case, the surrogate virus neutralization test. So S1 is the spike protein, and then this is the reactive binding domain of the spike protein, and this is the detector. And then they also copied the most common receptor on tissue culture cells, no, or respiratory cells, no, that makes the viral entry into the virus more active, more efficient. This is the ACE2 receptor in the surface of the respiratory epithelium. Actually, there are two of these receptors, no? The ACE2 and the TEMRAS, but I think they have utilized the most commonly identified host cell receptors. So the receptor plus the antigen portion of the virus, which is the spike protein, and the purpose of your antibody is to stop the binding of the ACE2 with the with the spike protein. The problem, however, is it measures neutralization. But the issue here is how much neutralization is protective of you, because it has not been standardized. No? And these are the ones, and what kind of cutoff are you going to use? So these are the ones that that gives them sometimes a false sense of security that, oh, it's really high up to the high heavens and I think I'm protected. And all of a sudden they will call me and say, how come I developed breakthrough infection? My titer was high. So I have to explain to them that the spike protein design is based on the most common binding sites of the active binding domain of the COVID virus. Unfortunately, the spike protein and the reactive binding domain of the COVID-19 virus is also one of the most area that mutates. No? That's why we have variants that has different versions of the reactive binding domain that may be unrecognizable to the neutralizing antibody. So it still happens, and then it identifies the protective mechanism from that, and the value now tells us whether are all of this really neutralizing in the net. So I think there was this article that was released in Journal of America, JAMA 2021, about the problems with the antibody testing for SARS-CoV-2 immunity because of the lack of the surrogate that are actually well established. Understandably, it's really a challenge for diagnostic test developers. No? I could feel the the the, the frustrations also. But this is one thing, because even the developer of the technology states that customers should not interpret the results of this test as an indication or degree of immunity or protection from reinfection. So that's why I keep on telling them that, having the virus is nice, but whether do you really have significant protective antibody? You have neutralizing antibody, but is it protective enough for you? And that's the one that needs to be challenged. So, because how high should the titer be to tell you with certainty that that particular value is the cutoff for immunoprotection? Or is this a cutoff to determine the degree of exposure, but is it protective enough or for you, or is it, what are the cutoffs and the expectations in terms of the different variants? Since variants mutations are classified based on the mutations of the reactive binding domain of the spike protein. So this is some of the questions that were raised. No, that's why every time that is actually being asked, I give them a cautionary advice that the technology may still have its utilization, but not as a tool to lower down your guard. So that's my discussion, my usual advice to them. Now, in terms of molecular diagnostics, you are all familiar with PCR technology, the one here in the middle. But there are other molecular-based tools, such as the antigen detection-based assay here, and then the isothermal technology here, which is a colorimetric tool, and then some are using combinations of lateral flow and CRISPR technology to identify the SARS-CoV virus. But it all starts with a good analytical sample. So kung mali yung pag-collect, mali na lahat papunta dito. And then the ones that I think has gained more recognition now because of our constant monitoring of the circulating variants at the Philippine Genome Center is the sequencing technology here, which can actually be divided into several sequencing platform, either a nanopore-based sequencing or sequencing by synthesis. No? And of course, the preparation is very tedious because you have to do PCR amplifications and library preps before you actually do the actual sequencing technology, which is not very practical in the daily utilization rates of the care. So for most virological testings to determine active viral presence in the host cell, the gold standard has been PCR technology. So nucleic acid-based testing that falls under that category use nucleic acid amplification and product detection targeting the SARS-CoV-2 genes, and these are divided into the RT-PCR or the reverse transcriptase polymerase chain reactions, or ddPCR or the digital droplet PCR that can actually pick up small copies of the virus under droplet technology, which really has a much higher sensitivity than RT-PCR. The problem is the machine needed to convert them into a droplet platform is also very price limiting. So when you do the calculation and you do the math, it's not practical for general use. The other one is the reverse transcriptase loop-mediated isothermal amplification platform, which amplifies the nucleic acid technology, which just single temperature threshold. So this is the technology that we used for our dengue technology. We also have our versions of the COVID using the LAMP, but we're still working on its timing, because right now everybody prefers the RT-PCR, but it's just there. The antigen test is a detection of viral antigens by specific binding to antibody, followed by optical, magnetic, or electrochemical visualizations of the interaction. The targets for most of these antigen tests targets portions of the virus, such as the nucleocapsid, the spike protein, the envelope protein, and the membrane proteins, which are the four most common targets for antigen detections in any virus tech development for antigen detection tests. Now, your RT-PCR and your antigen has the same intended use. No, it can detect current infection for both. No, the analyte detected by the RT-PCR is the viral RNA product after extracting using the nucleic acid extraction technology. Whereas the antigen test, you just have to process the sample to express the antigens in the solution, and now it can be used directly by the antigen test. The specimen type for the RT-PCR could be swab, sputum, saliva, bronchoalveolar lavage. No? But for the antigen test, it was mostly intended for a swab technology. The sensitivity is high for the RT-PCR and of course moderate for the antigen, but both of them has very high specificity. And in terms of test complexity, it depends on which RT-PCR platform you are using. If you are doing single step, one step, double steps RT-PCR platforms, or that makes the technology a little bit more complex, or if you have those cartridge type wherein it can now be easier to use. No. And then for the antigen test, it's relatively easy to use because most of the time the platform is point of care in platform. For RT-PCR tests, some are still struggling to convert them into a point of care platform, but there are now micro PCR technologies that utilizes high-end ceramic technologies for much controlled temperature sample processing. The turnaround time ranges depending if it's a digital droplet PCR, that's 15 minutes to 2 days, depending on how efficient is the management of your laboratory. But for the antigen test, it's about 15 minutes, and the cost is a little bit is different. RT-PCR test has a moderate price tag, and the antigen test is generally low priced compared to the RT-PCR. Now, in terms of the analytical performance of PCR-based study, out of 13 studies involving 2,255, has an average sensitivity of 95.2% with a confidence interval of 86.7 to 98.3%. So pag may naririnig kayong the sensitivity is 100% and the specificity is 100%, no such thing. Those are laboratory performance sensitivity report because there are no 100% diagnostic tests in the world right now. Because there are external factors affecting the integrity of the results. Kahit maganda yung test mo, pangit yung pagkakolect, bababa ang sensi. Kahit maganda yung test mo, inappropriate yung time of collection, bababa. Maganda ang test mo, pero yung processing ng pre-analytical sample, hindi maganda, bababa pa din yung sensitivity. So that's why they look at the clinical diagnostic sensitivity, not the laboratory performance diagnostic sensitivity. Magkaiba po yan. So in terms of the analytical performance of the antigen test, it has an average sensitivity based on 8 studies of about 56.2% with confidence interval of 29 to 79.8%. And the average specificity is about 99.5%. Which means, pag nag-positive ka, you are 99.5% sure that you have the COVID antigen in your body. If you test negative, there is still a chance that you may still be positive. That's why you have to advise patients that even if you test positive, if you had significant exposure, can you wait it out for a few days if you will develop symptoms or not? And that's the utilization of the advice. Instead of saying, ang pangit mong test, hindi na pick up, nagka-COVID ako. But these are intrinsic challenges of existing diagnostic platforms. So nucleic acid-based platforms such as RT-PCR remain to be the gold standard for COVID-19 testing. Improved primer and probe design and control over pre-analytical variables is expected to improve its clinical performance. Although antigen detection tests are limited by its low accuracy, they remain as a promising cost-effective platforms for population-wide mass screening and point-of-care use. But there are a lot of unmet needs in COVID-19 diagnostics. The scaling up access to diagnostic testing has become a challenge in the past, but I think we're learning from that experience and we are revising and streamlining some of the regulatory requirements as we speak. Alternatives to useful specimen types, collection devices, and transport media need are needed for still requires for clinical validation on the utility of non-respiratory specimen like urine, stool, and all the other samples. But I think for this particular illness, the respiratory sample remains to be the most ideal in this situation. A short and medium-term pipelines for de-isolation decisions is also an unmet need in diagnostics. So there is a need for a more accurate screening of asymptomatics and determination of live viral sheddings. Ito talaga yung pinaka-powerful sana, no? If there is a technology that can determine live viral shedding accurately, no, that would be a good de-isolation technology, and I hope someone can develop such technologies. No? There is also a need for the standard quality assurance protocols for all, for us to have our own wide-scale independent evaluation of emerging tests, to empower our laboratories, because they are actually handled by very able pathologists who are actually trained on validating and establishing quality assurance protocols for emerging technologies in their laboratories. Access by low resource setting as well. You need for long-term scaling up of manufacturing and efficient supply chain to become a disruptor and make the technology that used to be very inaccessible to most people is now being democratized and improving access to the marginalized sector. So I guess one of the question kanina yung pagpasok sa eskwela. I like the comment of that young 18-year-old lady. Mukhang pwede siya maging doktor or policy developer or politician, the way she handles herself. Now, there is the technical advisory group for schooling during COVID-19. Take note, this is from the European setup. So everything that is stated here should be taken with a grain of salt and determine its applicability in the Philippine setting. The way I always look at it is, what is the minimum requirement that will allow opening of the schools without adding to the risk of transmission? No? If you ask my opinion, opening the school is actually one way also of protecting our children from the mental pressures of doing online schooling. No? And if there is a way we can help make it safer for our children to have the right environment for learning, that's the goal that we should be setting. So if you ask my personal opinion, this does not represent the institution that I am representing right now, but my personal thoughts about it is that I really want the school to be open, even in the presence of COVID, provided that all of the measures are actually in place. And the strongest measure that we can actually have is vaccinating everyone around our children until the indications for vaccination, which is actually being done now in other parts of the world, be already downloaded to our kids here in the Philippines. So the COVID testing, the technical advisory group supports the above and advises that the value of PCR and rapid diagnostic antigen tests in school settings in opening schools and controlling transmission needs to be evaluated based on their effectiveness, cost effectiveness, and feasibility. Personally, I do not want this as a requirement. I would rather have targeted PCR testing for those who actually had very vulnerable family members at home. But as a full testing every so often, I find that very impractical. Testing should be prioritized for symptomatic children with acute respiratory infection in any of the severity if they belong to a vulnerable group, risk group, or are in a special situation with a high risk of further spread. But asymptomatic high-risk exposure or close contacts of cases should also be considered for testing. So meaning hindi siya test all, targeted. Sorry. Testing methods should consider diagnostic test accuracy, the need to test if infection spread, whether the student is isolated, frequency of testing, material for testing, support for testing, and follow-up measures for a positive test. But I agree, no? It's easier to be implemented in countries that are actually so subsidized or supervised. But is testing really technically? And if you ask yourself, if I have the money and I don't have the money, is the finances the only reason why I will not advocate regular testing in the school set? In my mind, I would probably recommend targeted testing and not mass testing in school, whether you have the money or do not have the money for it. Vaccination has been the most useful tool in preventing deaths. A positive test result or a negative test result doesn't mean that the child will not develop symptoms 5 days later and continue infecting because the previous test was negative to start with. And you cannot test them on children every day. You know? And that's impractical, that's out of the question, and that's even ridiculous. So cluster investigation in children's school settings should be organized in a way that enables continuity of learning, and that routine temperature or symptom checking in schools should be avoided as no evidence is available to support their use. Kasi nga, you can be infectious even if you are asymptomatic. No? And if you look at asymptomatic rates, you don't know how much of that is actually needed. No, how many students you have to test to be able to pick up percent asymptomatic cases. No, so the cost benefit of that over standard measures for control needs to be balanced for testing and opening school. So there are a number of diagnostic platforms that currently exist. Deciding on what platform to use depends on the availability, diagnostic accuracy, and timing of infection. Novel diagnostic techniques are continuously being introduced. Adoption of these technologies in the future will depend on the regulatory policies, which are currently inadequate. So to navigate the maze of COVID-19 diagnostics, a multidimensional point of view should be adopted by test developers, policymakers, and clinicians. And this view should include the technicality of the test, the population to be tested, the intention for testing, and the regulatory monitoring of the test. Thank you very much.
Thank you very much. That's Dr. Raul Destura. No? Kung napakalinaw ng kanyang paliwanag. No? And I think, well, I can see some of you have questions, so please put your questions in the chat box. And later we will have Raul in our panel discussion to answer some questions. So thank you very much. I think we're always enthralled by your presentations, Raul. Okay, so let's go to our next speaker. It's my honor to introduce a colleague, okay, at the Philippine Red Cross, who I've had the chance to work with. And wala akong masasabi, wala pang mas masipag dito. Ewan ko kung sino nang mas masipag dito. She is the head of the blood, ano bang tawag dun? Blood Services.
National Blood Services.
National Blood Services Director. And she's internationally known for her work in the International Federation of the Red Cross Red Crescent movement, because the Philippines has 88 or even more, I don't know if I have the right number, Monina, but more than 88 blood banks all over the Philippines. And she has been doing screening, testing, and using an RT-PCR for the longest time, you know. So we thought we would invite her to give a reaction to Raul's presentation, to talk a little bit about what the Red Cross is doing, has been doing, and just to share her thoughts and her experience with us. So I'm very honored to welcome a friend who day and night, anytime in the day or the night, if you need blood, she's able to get it and to move it along through the organization of the Red Cross. So Dr. Christie Monina M. Nalupta. Monina, welcome to the webinar.
Thank you very much for the kind introduction, Dr. Susie, and the invitation po. Actually, it was Dr. Susie. She's very instrumental also in developing our molecular laboratory when the pandemic happened. She was one with us in setting up yung ating molecular laboratory, no? Excuse me. While Dr. Destura reported about the diagnostics, different diagnostics for the SARS-CoV-2 infection, no? Yung applicability naman ang i-share ko, particularly with the antibody testing, because we've been operating also a convalescent plasma center in Port area, Manila. But before that, of course, you all know that the Red Cross has RT-PCR swab test, no? And we've been very active since the very beginning of the pandemic. And right now we have 14 molecular laboratories. And aside from that swab test, we engage with ang ating saliva test, and that's also RT-PCR, no? And it was through the leadership of Chairman Gordon when he contacted actually Dr. Ranyola of the University of Illinois and she is a fellow, together with Dr. Pau Ubial and Dr. Michael T. of UP. They presented our study, the Red Cross study, for the HTAC to approve the RT-PCR saliva test of the Philippine Red Cross, which we started in February of this year. And from February to up to date, of course, we already had more than 1 million saliva tests. And this is very important, since at that time in February, the RT-PCR swab test was high-racketed in the testing fee as high as 4,800. And when we introduced this, we offered it at 2,800, but right now it is more affordable at 1,500, and it's the RT-PCR technology. And the public really save, or the government really save a lot with this saliva test, the RT-PCR, about 1 billion pesos savings for this saliva test. Now, going back to my topic regarding the convalescent plasma and the antibody testing for SARS-CoV-2, just a brief introduction that the convalescent plasma for COVID-19, it's a passive antibody therapy taken, of course, from a recovered SARS-CoV donor, no? And it contains neutralizing antibodies against the said infection. And it's still an investigational product, usually transfused for severe to life-threatening cases, and it was given a compassionate special permit for its use. And in the Red Cross, we were able to operate and be given with a certificate of compliance last year of July 2020. That's when we started our operations, no? And of course, aside from the basic eligibility requirement as a blood donor, no? These are also some of the hematological and serological requirements. We do subject the blood samples of our blood donors to, of course, CBC with platelet counts, because the manner in which these plasma donors donate in the Red Cross is either through whole blood donation and apheresis donation or apheresis donation. And of course, it's mandatory to test our donations to the 5 TTIs like hepatitis B, hepatitis C, syphilis, malaria, and should be non-reactive. And for our CP donors, red cell antibody screening. And as what was mentioned earlier, SARS-CoV antibody test, and it should be at a titer level of 1:160. So moving forward, we employ the use of a quantitative test for antibody testing for SARS-CoV-2, and it is automated a chemiluminescent microparticular immunoassay test. It's a quantitative IgG determination specifically to the spike protein of SARS-CoV-2. Earlier, Dr. Destura mentioned about this particular assay, and its sensitivity is about 98.3% and specificity of 99.4% based on the study conducted by UK as published in the Journal of Clinical Microbiology. Actually, we were able to use the SARS-CoV quantitative IgG determination just this mid-May until now, because prior to that, this hasn't been available. And we were still using then the qualitative method of IgG antibody determination. And this qualitative method is directed towards the nucleocapsid. And it can only detect the presence of antibodies for active or natural infection versus this quantitative method that which can detect both the humoral response to a vaccine and the natural the response to natural infection. So with the test that we are using, it was actually compared to the plaque reduction neutralization test. That's the PRNT. No, again, Dr. Destura mentioned this one, and they compared the quantitative assay values, this one over here to your right, versus the titers, the PRNT dilution by way of a study at the Broad Institute, and subjecting about 86 samples, no, and positive samples, and the positive, the PPA or the positive percent agreement to the test that we are using is about 100%. But as a requirement to a CP donation, convalescent plasma donation, we need about 1:160 titers equivalent to the quantitative value of 3,200 to neutralize an infection. Okay, so just to show you the number of tests done by the Red Cross using this quantitative IgG test for SARS-CoV-2, from May 26 up to November 15, we were able to do about 228 tests, and those that qualified based on the requirement, the cutoff requirement of 1:160 is was only 107. Okay, so 24 of which were due to less than 1:160 or low IgG. By the way, a person is positive using this method to an antibody if the value is 50, okay? 50 arbitrary units per ml. But of course, we need more to neutralize the SARS-CoV infection, and that is more than 3,000 or 3,250 50. So 24 were deferred due to low IgG. And these were the results of the quantitative IgG assay for SARS-CoV-2. The total number of donors with breakthrough infection, meaning they've been vaccinated, then they acquired infection, that's about 90 donors. So out of the 90 donors, we got about donors who had 1:160, 14. 1:250, that's 14. And a lot were more than the required cutoff, the one, and that is 100, 1:640. Okay. And those the results of those unvaccinated donors with natural infection were only 17. And those gave a 1:160, 2 donors, 1:250, that's 4 donors, and 1:640, it's also quite a lot. That's 640 donors. No, we have more donors for those breakthrough infection because we've been very active in vaccinating here at the NCR. Rather than those donors who passed, who were unvaccinated and passed the antibody testing, the required antibody cutoff value. Okay, just to show you that the Red Cross has been active in a convalescent plasma program, and since the time we operated, we were able to dispense about 1,162 units, okay, until yesterday. And we serve about 1,025 patients. And hospitals who access the Red Cross, basically here in NCR, in Region 4, in Region 3, and some of our units were still shipped or was accessed by people or patients in our hospitals in the Visayas. It's 113 hospitals served. Okay, and for this year, we were able to serve almost 500 units. And of course, there's also a recommendation by the PSMID, NAT, of course, NAT, and they are against the use of convalescent plasma in patients with COVID-19 infection. Okay, and but actually, even if there's this recommendation, during surges, we still get a request on a monthly basis of about 100 to 200 units. That was in April and May. And lately, during the surge in August and September, about 100 units, and daily, a few of them still access for convalescent plasma products for their patient. And when they do access, of course, our infectious disease specialist communicates with us asking for the titer of the products that we will be issuing, and then they're really very strict that we comply with the minimum antibody titer of 1:160. So this was the report of the Department of Health National Voluntary Blood Services Program. Currently, we are still on a status quo. We do still operate a convalescent plasma center together with the different hospitals and the Philippine Blood Center. And even if there's a recommendation by the PSMID, and we will continue for as long as the DOH says so. And actually, the NVBSP are about to speak or coordinate and communicate with the expert technical panel on how we move way forward, because of definitely the request has been reducing, and we're actually spending a lot in regards to the operation of convalescent plasma. So that's all for my presentation. Thank you very much to all.
Thank you so much, Dr. Nalupta. Very, very welcome updates po coming from the Philippine Red Cross on testing for blood products and really something that we should look forward po mamaya sa ating Q&A panel discussion. We hope you'll be able to stay on, Dr. Monina. Next up, we have our next speaker coming in to provide a perspective po. He is a pathology consultant at the Department of Laboratories of the Philippine General Hospital. Please welcome to the webinar, Dr. Jonathan P. Rivera. Dr. Rivera?
Hello, sir. Good afternoon to everybody attending this webinar. I'm Jonathan P. Rivera and a pathology consultant in the Department of Laboratories in Philippine General Hospital. And on behalf of the Department of Laboratories, let me congratulate Dr. Destura for that very well done presentation. So he was able to cover most, if not all, of the most vital and important details when it comes to SARS-CoV-2 testing. And he was also able to relate it to the clinical and public health standpoint. So that is actually quite very important. So my job here as a reactor, I think I will not be able to add additional info to what the Dr. Destura has already provided. But instead, I will present to you our experience here in PGH, what we were, since the pandemic, what we were doing, and the number of tests that we've been able to do in the hospital. So let me just share my slides to you. This is just a quick, very quick presentation. So for the first slide, so since May 2020 up to the present, you can see that there is an uptrend in the number of tests done for SARS-CoV-2 in PGH in Philippine General Hospital, represented by the orange bar graphs. You can see there is a constant uptrend peaking till September 2021, which most likely represented the recent surge that we experienced in the country. And then it slowly dropped down in October and dipped down to the lowest, to a low in November 2021. You can see also from the graph, the blue colored bar graphs, which represents the positivity rate. So the positivity rate has its peaks on April 2021, around August, and around September. And the lowest positivity rate is today in this or within the month of November, and it ranges from around 3 to 4%. So the data that we have in PGH, the number of tests that we've done and the positivity rate, seems to reflect the DOH reports that we see in the news. During our testing, we've been able to send some of the positive samples to PGC to be sequenced. And from those positive samples, we were able to identify the different variants of SARS-CoV-2 in the hospital. So the most frequently identified is the Delta variant, followed by the Beta and the Alpha variant. In the hospital, we have several platforms, but all of them use the NA80 or they are all nucleic acid tests. And they are either a plate-based platform or a cartridge-based. But again, all of them are PCR tests. And we try to achieve a very acceptable turnaround time. So for our plate-based or routine runs, we usually are able to release results within 6 to 8 hours after receiving the samples in the laboratory. For urgent cases or patients needing immediate triaging, so we can usually provide results within 2 to 4 hours by using our cartridge-based platforms in the form of GeneXpert and BDMax. No? At the same time, the pricing in the hospital follows the circular provided by the DOH, the price cap provided by the DOH. So our tests are quite affordable. Now, on the horizon, we have already submitted our parallel testing with regards to saliva RT-PCR when parallel to our routine nasopharyngeal swab RT-PCR. Our data has been sent to RITM, and we are just waiting for the validation. And if we are deemed qualified to perform saliva RT-PCR testing, then we will decide and think where to put that modality in our existing workflow. So as Dr. Destura presented earlier, each modality has its own pros and cons, and you have to think carefully how to utilize them to their fullest potential. Okay, we're also eyeing in the horizon pool testing. So as we get a more stable supply of PCR kits, I think in the future we can now start testing or validating pool testing in the hospital. Unfortunately, with regards to antigen testing, this did not pick up in the hospital. Although there has been a previous donation of antigen test kits, the request from physicians did not really pick up. So antigen test kits, they are mostly beneficial in areas or regions in which your nucleic acid test kits or PCR tests are not available, or if they are available, the turnaround time is quite long. So patients that needs immediate attention and management will benefit from antigen test kit while still waiting for the PCR test. But given in the hospital that we have a very acceptable turnaround time, and our current PCR modalities and platforms meets the needs of the hospital, the antigen test kits did not pick up in practice. So that is just my presentation, and hopefully I have shared I've given you an insight on what we have been doing in PGH.
Thank you so much, Dr. Rivera, for giving us a glimpse of your work at the Philippine General Center. We hope that's something that you could also delve a little more in detail mamaya po sa ating Q&A panel. And then for our last reactor and speaker for today, last but not the least, he will be sharing perspectives coming from the private sector. Please welcome to the webinar the General Manager of the Lord's Grace Medical Industrial Clinic, Jessie Diatre. Jess?
Good afternoon, Doc. Good afternoon, everyone. I would like to share with you my slides. So, in views of this, yung experience and kung paano na nag-grow yung laboratory and testing, kung ilan na yung na-test dito sa laboratory namin. So, I'm Jessie Diatre. I'm the General Manager of the Lord's Grace Medical Industrial Clinic company here in Pasay po. So, according to the data of the DOH, nagsimula po kami, we started our laboratory last week of September 2020 up to the November 10, yung data ko, we accumulated or processed about 266,500, and about that, about 29,523 ang positive namin. So we gathered 11% positivity rate last throughout the year na nag-run kami ng sample. So here's the sample tested. We offer the RT-PCR, rapid antigen, antibody. We have the rapid ICLI and ICLIA. We have also the RSBD, or yung equivalent or similar to neutralizing antibody. For RT-PCR, as of September 2020 to November 10, we already processed sample 266,500, and for the antigen, we have processed the 24,000 samples. For the antibody, we have 6,000 samples, and for the SRBD, we have 400 samples. So, aside from the evolution of the technology, we also have challenges in the laboratory, specifically yung reaction of the of the patient or some client. So ano yung mga na-encounter namin since na topic na ni Dr. Destura yung mga scientific cases and si Dr. Nalupta in terms naman sa convalescent, si Dr. Jonathan naman is on the sa view naman ng public sector. Sa amin, na-encounter namin sa private sector is yung patient tend to do laboratory hopping or shopping for COVID-19 testing on one of the biggest challenge na na-encounter sa laboratory due to different results obtained in the PCR. So, ang nangyayari after that, pag once na nag-release ka ng positive and then magta-travel sila, they go into another laboratory. Then later on, if nagkaroon sila ng negative results, they're going to backlash the laboratory who released the positive result. And here are some dilemmas that we also encounter sa aming laboratory po. So one po na na-encounter po namin is patient highly expect the laboratories to interpret the result instead of consulting their own physician for medical advice. So they're usually, pag they receive the results, they're always asking the laboratory to interpret the results and give some advice. So we usually advise them to consult their own physicians or the infectious control doctors. So the second dilemmas that we encounter is denial in their test results for positive cases, which lead to multiple complaints, sometimes legal demands, social bashing, and hassle. So na-encounter namin yan sa social media namin na pag nagkakaroon ng positive results sa kanila and then they go into another laboratory, tapos nag-negative sila, they're always complaining into our website. The third dilemmas that we encounter is a patient undergoing multiple RT-PCR tests with different institutions will turn out negative and eventually backlashing the laboratory who gave out the positive results. So lagi talaga yan, as in hindi lang 3 or 5 beses yung nangyayari sa isang araw. Minsan they're always complaining and then may minsan nagte-threat talaga. So, yun yung mga nakikita namin na medyo nakaka-hindrance sa pag-move forward ng laboratory because of the complaints of the patient. Next is the patient relying on the laboratory to conduct the proper test instead of consulting their physician for the proper test needed. So, pupunta na lang yung mga pasyente just because they wanted to know their status, pero pag tinatanong mo sila kung ano yung reason kung bakit sila magpapa-laboratory test, sabihin lang nila na gusto lang nila. So, yun yung mga bago ngayon na nakikita namin sa molecular compared doon sa routine laboratory or clinical lab natin, because if you're going to give them the result in the clinical laboratory setting, pagkatapos nilang na-receive yung result nila, automatically they consult the doctors. Ngayon, ang mga pasyente, if you're going to give the result to them, ang gagawin nila is tatanungin na agad nila yung laboratory ko ano yung interpretation. Of course, sa laboratory hindi namin ini-interpret din results. And that would be the end of our of my presentation po. Thank you po, Dr. Raymond.
Thank you so much, Jess. As we try to move on to our panel discussion, may we call on each of our speakers to open up their videos po. Well, we're seeing the poll being flashed on the screen right now. Pero hintayin lang po natin mag-open po ng kanilang mga camera. Okay. So, sige. Before we go into our Q&A, we'll take a very, very quick break lang po, no, for our special public service announcement for today. Take it away, TVUP.
O Apo, mukhang malalim yung iniisip mo, ha? Wala ka mapasok ngayon?
Wala po. May disinfection kasi sa grocery.
Ah, ganun ba? Eh di ba wala rin kayong pasok kahapon? Pati nung isang araw?
Sana makabalik na ako sa trabaho.
O siya. Di na muna kita istorbohin at mukhang malalim yung iniisip mo.
Lo,
O no?
magpabakuna na kaya tayo?
Walang problema, Apo. Paunahan mo lang ako eh. Talaga.
Dahil mahal ko kayo, magpapabakuna ako.
Thank you so much, TVUP. The COVID communication public service announcement is one of the many outputs of the UP research entitled Communicating COVID-19 in Post-Quarantine Philippines, headed by our UP Vice President for Public Affairs, Dr. Elena Pernia, and funded by the Department of Science and Technology, PCHRD, and the Department of Health through its AHEAD HSPR project. Over to you, Dr. Susie.
Okay, thank you very much, Raymond. And thank you to all our speakers. Nako, very good presentations. Now we'll go into our panel discussion. We're going to get some questions from the audience, but let me start with a situation question, and anyone can answer it. But I think Raul maybe no. We know that many people received Sinovac, and their thinking is that they received Sinovac and they want to know if they are protected. And so what they do is they want to get an antibody test to see if they have antibodies. So what's your advice in this situation? Because even our health workers are asking that question. Sige, Raul, go ahead.
I get that question almost every day from my colleagues regarding the antibody test and whether it is a measure of protection. Unfortunately, the existing tests we have at the moment, for lack of standardization cutoffs to determine immunoprotection, are not useful enough to provide that information at the moment. The challenge there is we kind of use the number as a basis that, it's high enough. That's why we think we are protected. And then all of a sudden, they will call me up. I had a breakthrough infection in one of my patients. The problem with testing measurement, the antibody levels, it is a total antibody measurement in most of these tests serologically. It does not discriminate how much of that antibody level is neutralizing and how much is non-neutralizing. So just getting the titer is not a direct measurement of immunoprotection. It just tells you your intensity of response to the infection. That's why the variability in the levels of immunoprotection is a big challenge, because what would be your cutoff? Because the data of immunoprotection is still in a flux. As data comes in the future, we will be able to identify the critical threshold level to say that at this particular level, that particular cutoff set is immunoprotective enough. Obviously, with the current cutoffs that some of the tech developers are putting out are based on in vitro data, but doesn't translate to herd immunity levels or immunoprotective levels for lack of the standardized test. These are just surrogate markers that provide you the measurement of the degree of the immune response. We know that even if you have high elevated antibodies for certain viral diseases, that doesn't mean that you are protected. Example, if you measure your antibody levels against influenza, it's high. But why do you get influenza again that particular day, that particular year? Because of the rapidly changing antigenic response to that particular virus because of mutations. So that's why kaya nagre-revaccinate sila, di ba, almost every year, despite of that, no? The coronavirus is also one of those viruses that during the replicative state mutates every 2 hours. No? And sometimes the mutation is non-consequential. And sometimes the most dangerous part is if it becomes consequential because we are now dealing with the variants. So measuring the levels of antibodies to a specific disease, like COVID virus, doesn't mean that you are protected from all of these variants. So sometimes there is a transitioning between two areas of concern. One is the epidemic of the variants affecting both vaccinated and non-vaccinated, and then the epidemic of the non-vaccinated, which is the scarier portion here. So what do we have so far to base our level of confidence on vaccination and decrease the level of vaccine hesitancy? What we have as data is that though you may have breakthrough infections coming from if you are vaccinated, the protection level for the severe form of the disease is still high up there. So kung magka-develop pa rin ng COVID on an individual basis, the risk of you from dying from the disease dramatically goes down if you are previously vaccinated. But the problem is, if you have someone in your household vulnerable, refusing vaccination, sila ang pwedeng magkaroon ng disease na matindi, no? Hindi ikaw, no? Yun yung kaya kahit bakunado, ini-advise pa rin natin yung mga tao to do the social distancing, the wearing of the face mask to protect the vulnerable population, especially those that you love, no? The elderly ones who may have problems developing immunoprotective antibodies. So to use a serological level as a basis of confidence that I am protected can be misleading at this point. No? So kung nire-request yun, dapat sasabihan palagi ng advice na this is actually a basis that you develop an immune response from your vaccine. But this is not the basis for you to say that you are protected forever, no, from the virus. So which means that you need to be cautious about it and think about the people around you who have contraindications to receive the vaccine, or you have the host profile that makes vaccine intake, no, a little bit less than those that have intact immune system. These are the elderly, the receiving immunosuppressive drugs, just had chemo, no, receiving high dose steroids for autoimmune diseases. So these are the ones that a little bit of a concern, no, that may not have more effective vaccine protection than those who do not have this kind of risk factor. So bottom line is the current serological measurements to determine protective antibody levels are still very limited. Not because the kit is wrong, it's just because of the nature of the virus. When the spike protein segments of the virus, which is the one utilized to target measurements of the antibody levels, changed, nare-recognize yung total antibody levels, pero yung protective levels of the targets are not there because it's a different variant of the virus. You can still have breakthrough infection. Two things, either a breakthrough infection because of significant mutation of the virus, or in your case, you have a rapidly waning immunity, no, compared to other individuals. So it can be either or a combination of both reasons. So if patients would still request for those tests, it's best that the doctors provide them the proper advice on what to think about, no, when they have those results. This is what you call managing expectations. Otherwise, ayan na naman, social media bashing, si doktor ganito, ganyan, si laboratory ganito, ganyan. So I think it's really a failure of communication sometimes on the pros and cons of these technologies, no, that is being offered to us. Take note, we are dealing with a pandemic, and the need for rapid technology availability is always up there that sometimes, even if it requires months and months to be tested, validated, reevaluated, and reevaluated again, you don't have that luxury. So sometimes we have to do with what we have. But the most important thing are the caveats of this technology that we need to be able to translate effectively in a language that is understandable by the non-medical community or even some medical community. So ito yung challenge with all of these tests.
Yeah, thank you very much, Dr. Destura. I think Dr. Nelson, thank you, Raul. Dr. Nelson had his hand up.
Yes.
Sir, yes, go
I
ahead.
want to add a little bit to what Raul had said. Now, classically, when you get infected by something, you have two branches of immunity. One is antibody-mediated immunity, and the other one is cytotoxic or cell-mediated immunity. Now, when you get infected by a virus, in general, I think there is evidence, and people will hear me out on this, that ang cell-mediated immunity is more important in viral diseases than antibody-mediated immunity. So, ang minimeasure ng antibody levels, these are effector arms of humoral or antibody-mediated immunity, and we do not know kung ano ang kanyang cell-mediated immunity, which is also important because hindi siya minimeasure. The other item that I would like to stress is when this particular virus enters your respiratory tract, ang una niyang ma-encounter doon na structure is going to be the surface mucosa. It is a surface that is covered by mucous secretions. And in such a situation, ang antibody that is responsible for immunity there is secretory IgA at hindi IgG or IgM. So therefore, pag may minimeasure ka na IgG from the bloodstream, from the circulation, it could be different from what is occurring in the mucosa, wherein the real contact with the virus happens. So, hindi ka sigurado kung meron kang IgG in the blood, pero wala ka namang sufficient antibodies that are present in the mucosal layer, ay mukhang antibodies in the circulation do not tell the whole story. So that is the reason why we refuse to rely too much on antibody levels to say that you are protected or not protected or slightly protected from this particular virus, because there are so many factors in the immune response na hindi na-measure in this particular illness. It's only IgG, and early in the disease, also IgM and secretory Ig and IgA na minimeasure. Walang secretory IgA dyan. So the antibodies that we are measuring are not exactly the ones that first come into contact with the virus as soon as it enters the respiratory tract. So that is the reason why it is difficult to say na protected ka or not protected based on antibody IgG levels. Thank you.
Okay, thank you very much, Dr. Nelson, for that explanation. I think we have one question that we'll take from the audience, Raymond. Isa lang, kasi we're nearing the top of the hour. Please go ahead, Raymond.
Correct. So well, the two questions, I'll just choose the one that's
Yeah,
most
let's just move on.
upvoted. The question reads, what what's the laboratory quality assurance that is in place for COVID-19 testing? I think she's asking the protocols to make sure, and it's also very much what is echoed in the chat po, no? With regards to the chances that RT-PCR testing has an error, all of that. Maybe, well, we can ask Dr. Nalupta and then Dr. Geraldino afterwards.
Actually, in the Red Cross, in our molecular laboratory, of course, I think every year they do are being subjected to proficiency testing. That's on the technical aspect of our operations for the molecular laboratory, subjecting our medtechs, and definitely every day they do preventive maintenance and quality check. We have laboratory supervisors who really make sure that they do monitor the operation and doing quality assurance procedures every now and then. And even we have quality assurance auditors, that goes around those 14 laboratories once or twice a year. So they really need to double check if they are compliant to the procedures set forth by the government, aside from the monitoring done by the Department of Health to each and every laboratory of our Red Cross. You know that because lately we were actually visited by the Department of Health, So yun nga, Mr. Jessie Diatre actually mentioned the laboratory hopping. So it really is a very problematic practice that you do hopping when the timing of the collection is really different. So with all of those problems, at least somehow the Department of Health have reported that with the incident that happened to the Red Cross, it's really within the standards by the government. Thank you.
Thank you, Dr. Monina.
Raymond, Raul wants to say something about lab hopping. Raul,
okay,
go ahead.
okay. Dr. Destura.
Yeah, because this is a common problem, people think that when you test at one point in time, you're in that particular state frozen the whole time. So that's why you do lab hopping. Ito yung choose the best menu that can provide you the test that you want for yourself and not the actual test. So for example, if you test negative now, and then you can doubt it because you may feel a little bit of something. And then later on, you go to another lab and you have it repeated and you tested positive. Remember that the viral replicative process is a viral dynamics process, meaning your levels may be too low, kaya negative ka doon sa lab A. A few days later, nag-positive ka na doon sa kabila. Aawayin mo na yung kabila kasi negative ako doon, bakit ako positive dito? On the reverse side, nag-positive ka, hindi ka happy sa result, and lumabas yung result mo a day after or 2 days later. You go to another lab, negative ka na. And then pas papaniniwalaan mo yung gusto mong result. Kung gusto mo ang result na negative, doon ka sa negative. The answer to that is you are wasting your money. The specificity of the test is 99%. Which means that if you test positive at a particular point in time, you have the genetic markers for that. But later on, pag mag-negative ka, ibig sabihin either you rapidly shed the virus and the pickup is already low, then you will test positive. So unless you're really into the scientific model, you have yourself tested simultaneously all at the same time. Same time, same sample, at saka iba-ibang laboratory kasi minsan isa pang dahilan is yung pag-collect. Pangalawa, yung pag-transport. Pangatlo, so there are pre-analytical processes that can affect the behavior of the diagnostic technology. So so if you do laboratory hopping, ibili mo na lang ng cheeseburger yung gastos sa test. No? Sayang yung paulit-ulit. Oh, yeah.
Thank you very much, Raul. Okay, I think we don't have any more time. We would like to thank all our guests, and we're going to give you a minute or two to formulate your parting words to our audience. Our audience are mainly frontline health workers, as you can see from different parts of the country, hospitals, clinics, healthcare centers. So we'll give you a minute or two to do that. Meanwhile, Raymond's gonna file us, what's this? Show our evaluation poll. Oh, and answers to the questions muna, Raymond.
Yes, yes. Okay. Can we do that? The team. Okay, there we go. So this question comes from actually I'll just read it. So anong COVID-19 test ang tingin mo ang pinaka mahusay? So what COVID-19 test do you think is the best? The options are RT-PCR swab, RT-PCR saliva, rapid antigen, and rapid antibody. We'll call on Dr. Destura to reiterate his message for this item.
Yeah, the most powerful tool for diagnosing COVID-19 is the RT-PCR swab technology, followed by RT-PCR saliva technology, followed by the rapid antigen, and lastly by the rapid antibody. It's not because they're really bad, it's because the intrinsic limitation of the platform is the one that keeps it a little bit of a challenge.
Okay. And then for our second question, kapag positive po ba ako sa COVID-19, makakabiyahe pa rin ako? So that means if I'm positive for COVID-19, I can still travel. Is that true or false? Go ahead, Sir Raul.
Yeah, false. You shouldn't. You shouldn't travel if you are positive for the virus because the travel agency or the facility have no way of differentiating whether your positivity is in the infectious state or if your positivity is in the post-infectious state. So, ito yung public health decision naman. Oo, public health decision. Kung gusto mong kumontra, you consult an attending physician, have yourself evaluated, and take care of your health rather than your drive to travel.
Thank you so much, Dr. Destura. Team, can we have the evaluation poll? There we go. So we usually have this 5-question evaluation poll. During this time, our panelists will be gathering themselves to come up with their final messages to our audience. I'll read the questions, and it's a 4-point Likert scale. First is the panelists demonstrated thorough knowledge of the topic. Second, the panelists were well prepared and organized. Third, the panelists spoke clearly and audibly. Fourth, the panelists used appropriate language with technical medical jargons adequately explained. And number 5, the panelists contributed to new perspectives and knowledge on managing various key COVID-19 health issues. So we will continue to leave it open. And like we mentioned, wala pong separate na evaluation poll. Ito na po yun. We will wait for your answers and inputs po for this evaluation poll. Over to you, Dr. Susie.
Okay, thank you very much, Raymond. So we're going to ask our panelists to give their parting words for our audience, and we're going to start with Jessie Diatre. Go ahead, Jessie.
Yes, thank you, Dr. Susie. My final remarks is it's always better to consult and collaborate with other healthcare providers in evaluating the patient. This is very important in order to perform appropriate laboratory procedures. Again, do not be complacent because complacency could cost life. Stay safe and God bless.
Thank you very much. Yeah, thank you very much. We're now going to call on Dr. Jonathan Rivera.
Hello, ma'am. For my parting words, it's quite interesting to be invited in a webinar in which we don't only see the scientific side of things or the clinical side of things. So as the questions reflected, very ang important din yung public health standpoint. Yung mga laypersons, yung mga patients natin. So it reflects on their questions directed to us. And I hope in the future, we can have more webinars like this na hindi lang yung paulit-ulit na minimension natin yung mga different modalities. It's quite impressive that Dr. Destura was able again to relate the modalities and how it may help or impact the public health standpoint. Thank you.
Okay, thank you very much, Dr. Jonathan. We'll go to Dr. Monina Nalupta of the Philippine Red Cross. Monina.
Thank you very much po. So as we unmask this SARS-CoV-2, let us continue to work together. And on behalf of our Chairman Richard Gordon, our Secretary General, together with Dr. Susie, she is still a part of the Red Cross, the International Federation of the Red Cross. Maraming salamat po for the support and the trust you've been giving the Red Cross. We offer you our services in molecular laboratory, RT-PCR swab, saliva, and the different services that we can offer in response to COVID-19 infection. Salamat po.
Thank you very much, Monina, for those words. Okay, Raul, your turn.
Yeah, thank you so much for having me here today and the chance to explain the pros and cons of all the technologies available. But the bottom line here is diagnostic testing for COVID-19 is not the only solution to control the pandemic. It is a mere tool in providing us information for proper decision-making on what the next best thing to do insofar as the overall scheme of controlling. It is a responsibility of the clinical laboratory diagnostician, as also the doctors requesting for the test, as well as the individuals receiving the results of the test. This particular tools allows us to provide decision-making for clinical management, at the same time gives information to the country on how far we are in terms of controlling this pandemic. Again, no matter how well established and well played the plans are, or the battle plans for controlling, it will never run on autopilot. It means that each of us has a responsibility to do and to protect our country so that we can open our economy faster, and that so that our kids, our nieces and nephews can go back to school, and that the economy will start growing and create more jobs. Again, vaccinate, vaccinate, and vaccinate. Thank you.
Thank you very much, Raul. We'll go to Dr. Nelson, please. Your parting words. Is Dr. Nelson here?
I think he got disconnected.
Okay. So we'll now move to our synthesis and closing remarks. And it's our honor to have the Deputy Director for Health Operations of the Philippine General Hospital, Dr. Stella Marie Legaspi Jose. Stella, the floor is yours.
Hello. Good afternoon, everyone. This has been a very illuminating conference, and Dr. Raul Destura presented his talk. And actually, this graph that he showed was shown several times in this TVUP, even at the start of the pandemic. So this is just like a review for our followers in this webinar series. So 0 to 3rd day, you have the latent phase, and then you have the infectious state. And then he said that in the clinical presentation, from 0 to 5 days is the incubation period, and the patient becomes symptomatic up to the 14th day. And what we are seeing here is the degree of infectivity. So what is important is the timing of the PCR test. Now here in the PGH, if you think that this is a Delta variant, we get the swab, the RT-PCR on the 3rd day. But if it is just not non-variant, so just we get it on the 5th day. And the PCR test does not discriminate between a live virus and a dead virus. So even after the patient has recovered from the COVID-19 infection, the RT-PCR can still be positive. So what is important here is your clinical assessment of the patient. As you know, now there is what we call a long COVID, or the patient will manifest the symptoms of COVID even if it's not infectious anymore. Okay, so the antibodies, if you want to test for antibodies, should be tested on the 2nd week of illness. Now, the antigen is concurrent actually with the RT-PCR, but more studies are needed to validate this. Now, about neutralizing antibodies, what when you get your neutralizing antibodies, they will give you a level, but we do not know exactly how high it should be so that you will be prevented from having a COVID infection. But I would like to reiterate what Dr. Raul said, that it is really vaccination which is important. For those of you who go shopping from one test center to the other, what is important is if the patient is symptomatic and when the test was done. Okay, so in conclusion to Dr. Raul's lecture, the RT-PCR is the gold standard. I think he mentioned it again, and the antigen testing is very promising. Now, for Dr. Christie Monina Nalupta, I admire her work in the Philippine Red Cross. So, saludo ako sa inyo, ma'am, at marami kayong natutulungan. Okay, so nasubukan ko magpa-saliva test sa Red Cross sa Alabang and magaling. Very efficient at napakalinis. Wala akong masabi. For Dr. Jonathan Rivera, he presented the PGH data. And yes, so we see that it's going up, going down. We had already 3 surges so far. And now there is a surge in Europe. And so, hindi yan maglalaon, baka magka-surge na naman tayo dito. But if we are vaccinated, as many have spoken, even if you get the disease, it will be mild or moderate. But the deaths are very low or minimal, very minimal. Now, from Jessie Diatre, he presented the dilemmas in managing laboratories. I sympathize with you at mahirap nga talaga yung binabash tayo sa social media. Dapat nga, masama man pero gusto mo rin tuloy mang-bash ng tao. Pero wag natin gagawin yon, hindi yun tama. And we just have to enlighten our patients. Okay, thank you very much for this opportunity to give the closing remarks. Back to you,
so
Susie.
much. Thank you so much, Stella. So that's our Deputy Director for Operations of the Philippine General Hospital. So this brings us to a close. And before we say goodbye, I just want to encourage everyone to be with us next week. Nako, ang ganda ng topic natin. Sabi, ganito, stay safe, stay home daw. Pero nakita natin itong pandemya, ang taas ng rates po ng domestic violence and pag-aabuso ng mga bata. So we will have some experts who will talk about this, what to do, how to prevent it, where to report it, ano ang mga kailangang tulong ang gagawin natin. No? Kasi kung meron kayong mga nakikitang mga dinadalang mga bata or mga kababaihan na mukhang sinasaktan sa kanilang mga tahanan dahil nang nag-lockdown din ay medyo maraming naaburido, but that's not a reason, no? So we are going to talk about violence at home and COVID-19. So be with us next week. Raymond, over to you. I can see people are answering the evaluation on the chat.
We were having trouble with launching, ending, restarting, sharing the results of the poll. We hope that's something that we'll able to address after this webinar po. Thank you so much to each and every one of our expert panelists. Everyone really learned, and you'll be able to see that po, not just in their answers to the evaluation poll na nasa chat na ngayon, but also in their comments po when they were putting it in the chat. So maraming salamat po sa inyong lahat. Before we conclude our program, let's first acknowledge the very hardworking team behind the Stop COVID Deaths webinar series. Without each and every one of you, hindi po talaga mangyayari itong ating credible online community. Very thankful po kami sa inyong lahat. And finally, all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel at your convenience. Meron na pong 78 webinars na naka-archive po doon ngayon. After this webinar, magiging 79 na po. You can also view that in our other channels po in Facebook as well. So this formally closes our webinar for this week. Magkita-kita po tayo ulit next week. Same time, same channel, Friday from 12 noon to 2 p.m. We look forward to your company again next Friday. It's a date.
Together we can stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, I'm pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will